With now, invite speaker Dr. Dahlia Krishnan to present her talk, A Twist in the Tail. She's a medical retina consultant at Dr. Srikant Eye Care Hospital, Kozhikode, and she's an expert at treating uveitis and macular pathologies. So over to you, Dahlia, ma'am.
Thank you, Dr. Dahlia. Thank you, Drishti organizing team, for giving me this opportunity. So let's start the twist and the tails. So the case number 1, 63-year-old female patient came with blurring of vision in both eyes of 3 months duration. On examination, visions were 624 and 2/60, and anterior segment showed medium and large size mutton fat KPs in both eyes with severe AC reaction and plenty of cells in the anterior vitreous with cataract. So fundus examination, the media was very hazy due to numerous large vitreous opacities, and very hazily we could see multifocal retinal or subretinal yellowish white lesions in the fundus in both eyes. So we had a provisional diagnosis of bilateral granulomatous panuveitis. So the things which we were in our mind were sarcoidosis, tuberculosis, masquerade, of course. So blood tests were sent, and she was started on topical steroids with cycloplegics. So serum A's came positive, and peripheral smear showed eosinophilia. So we took a chest opinion, but there was no evidence of tuberculosis or sarcoidosis. So on follow-up of 1 week after topical steroids, the AC reaction had reduced, and we could see plenty of large white cells in the anterior vitreous. So now the posterior segment were also slightly more visible. We could see the vitreous floaters. There were some subretinal drosenoid deposits seen in the macula in both eyes, which is more in the left eye. And the multifocal subretinal cream-colored lesions were also visible more. So we did an OCT, which showed in the left eye multiple irregular RP elevations with sub-RP deposits seen in the macula. So this is suspicious. So this was the first twist. So our differential diagnosis changed. So now we were thinking of primary vitreoretinal lymphoma as the first DD. So we ordered MRI brain with orbit to rule out CNS lymphoma. The report came negative with just bulky lacrimal glands, and in fact they put a comment that there's a remote possibility of lymphoproliferative disease. So we advised for a diagnostic vitrectomy, but the patient was not willing of the MRI report. So we took an orbit opinion, but the lacrimal gland was not palpable. So even that risk was explained and the patient was not willing. So the patient came for follow-up after 4 weeks as it was not willing. Again, now the multifocal lesions had increased in size. Especially in the left eye, we could see large lesions temporal to the macula. The OCT, the sub-RP deposits had increased and become more extensive. So now there was an urgent need for a definitive diagnosis. So we discussed and convinced, showed all the scans, and the bystanders were convinced regarding the need of diagnostic vitrectomy. We also advised them a second opinion with Dr. Prakash at Comprest, and he did a diagnostic vitrectomy with chorioretinal biopsy. And here came the real twist in the tail. So the cytology report came positive for B-cell lymphoma. So now our diagnosis is bilateral primary vitreoretinal lymphoma without CNS involvement. So oncologist opinion was taken, advised systemic treatment. Patient was not willing because so intravitreal therapy was started with rituximab in both the eyes. Or 2 months follow-up, the AC reaction had reduced in both eyes. We could see medium large pigmented KPs, and fundus view, the subretinal lesions had reduced a bit. But within 3 months, the patient was admitted in the hospital with altered sensorium, confirmed to have CNS lymphoma. Systemic chemotherapy was started, but she expired in 6 months. So let's not end the tale in a sad note. Coming to the case number 2, a 62-year-old male who came consulted me on July 2025 with the complaints of increase in floaters in the last 3 months. So on ocular examination, it was a bilateral Fuchs-like presentation, diffuse stellate medium-sized KPs, and anterior vitreous had plenty of large white cells. So bilateral Fuchs is a rarity. So here itself the red flags came. So fundus examination, almost similar picture. Media hazy due to large vitreous opacities. It was a dull foveal reflex with few drosenoid deposits. So if you could see clearly, there was this drosenoid deposits in the perifoveal region, more visible in the left eye. So OCT macula was done, which showed RP thickening with nodularity, with changes in the ellipsoid layer. Fundus fluorescent angiography showed some stipple fluorescence in the perifoveal region. So here we had a bilateral granulomatous panuveitis with nuclear cataract in a 63-year-old with subretinal deposits, could be RP inflammatory changes. So our first DD was PVRL, but we wanted to rule out syphilis, sarcoid and TB. So the blood test was sent. IGRA came positive. So again, just opinion was taken and TB ruled out. MRI brain with orbit was done to rule out CNS lymphoma. And here the patient was willing for diagnostic vitrectomy, and it was done to rule out. And the vitrectomy sample was sent for cytology, which came as non-Hodgkin's lymphoma. The flow cytometry and the immunophenotyping confirmed CD5 negative, CD10 negative, B chronic lymphoproliferative disorder. So again, the diagnosis is bilateral primary vitreoretinal lymphoma without the CNS involvement. So the oncologist opinion was taken and started chemotherapy according to the De-Angelis protocol with rituximab, methotrexate, vincristine, and procarbazine, and intrathecal methotrexate. Intravitreal therapy was given with intravitreal injection of rituximab and methotrexate weekly once in the first month, 2 weekly once in the second month, and the third month intravitreal methotrexate 2 weekly, and the fourth month onwards monthly injection of intravitreal methotrexate. So post intravitreal injections and the chemotherapy, there is significant improvement in vitritis. The subretinal lesions are resolving, and the patient is going to have 9 months of intravitreal treatment. And also, they are planning for a bone marrow transplantation for this patient. So, on review of literature, primary vitreoretinal lymphoma is a very rare, high-grade malignancy of B-cell origin with a poor prognosis, and it's a subtype of primary CNS lymphoma. Up to 90% of patients with PVRL eventually develop CNS involvement. So, that's important. And also, 50 to 25% with primary CNS lymphoma go on to develop ocular dissemination of the disease. So, when I review the literature, this particular study from Marchesi et al. About the anterior segment involvement in biopsy-proven vitreoretinal lymphoma, they said that 51% of patients present with anterior segment involvement and different types of KPs, dendritiform with branching and irregular margins as seen in the second case, and large granulomatous as seen in our first case, and also dust-like KPs can be seen. Also, the OCT images of biopsy-proven was studied by Barry et al., which showed multiple OCT features of PVRL, but the hyperreflective subretinal infiltrates give a unique appearance of PVRL. So, my take-home points are you should have a high index of suspicion to identify PVRL in a timely manner, may present with anterior segment inflammation with different types of KPs and AC cells. But the vitreous cells are typically large and white. OCT is critical in the early detection of subretinal deposits and guide indication for tissue diagnosis. The gold standard for diagnosis is intraocular cytological examination, which is obtained by vitrectomy and chororetinal biopsy. A multi-team approach is required in the management of PVRL with the collaboration between the ophthalmologist, the oncologist, cytopathologist, and neurologist to optimize the patient's regimen. So my queries to Madam is, in this particular case, the second case, actually the vitreous sample was sent to 2 places. In one of the lab, it came negative, and from other lab, it came positive. So in such cases, if when you're suspecting PVRL clinically, if the vitreous specimen cytology comes negative, what should be the next step?
Repeat the biopsy.
Okay.
If somebody has actually started steroids, you need to do a rapid taper and stop it, at least for 2 weeks, because use of steroids, reduces the positivity of the sample. But if your clinical suspicion is very strong, I would say repeat it, because everybody says this, sometimes you need repeated sampling, to prove the diagnosis. The problem with intraocular lymphoma is that, it might show a partial response to steroid because it's toxic to the lymphocyte. And then, you have lost the time. Yeah.
Thank you, ma'am.
You want?
Ma'am, in your experience with PVRL, if you can share.
Oh, yeah. So, the 2 most common patterns you're going to see with PVRL is, it can be confused with intermediate uveitis. So it might present with just vitritis, or it can present with the subretinal deficits, which in certain cases can be really, really large. And on clinical examination, you might think it is a choroidal lesion. And there's some of the myths you have already talked about, that you think lymphoma will not present with keratic precipitate and cells in the AC, and that is not true. And the second myth is that it can regress spontaneously, leaving scars. Okay, so it can do that because your immune system does fight against the tumors as well. With the vitritis, what you normally see is the sheets of cells, coming in from the periphery. And in spite of the media being very hazy, their vision will be relatively better than what you anticipate. The subretinal lesions have a very classic appearance. You have this leopard's skin spotting. Okay. And that is very typical of intraocular lymphoma. If you have seen it once, you'll never forget it. And I think that the imaging modality which is best for picking up intraocular lymphoma is OCT. And even if the media is hazy, you should attempt to get an OCT through, if there is a lesion, try to get it through the lesion, not the very large lesion, get the smaller lesions. The large lesions will cause shadowing, and it's difficult to gauge it. The smaller lesion will tell you that it is exactly that subbar PE deficit. So it's subbar PE deficits or retinal infiltrates. And cystoid macular edema is usually not present in, yeah.
Thank you, ma'am.
Thank you, Dr. Dahlia, ma'am, for that.